Hi, I'm Matt Lunning from the University of Nebraska Medical Center in Omaha, Nebraska. Well, thank you for joining me today, and thank you for the invitation to come to give an update from ASCO 2022 here in Denver, Colorado, on lymphomas and lymphoid malignancies. You know, I started my talk off by really focusing on chronic lymphocytic leukemia in the upfront space. We've seen a lot of monotherapy data, or BCL2 plus CD20 data, BTK plus CD20 data, really emerging kind of in this space. And what I spent time on was talking about the phase 2 full dose Captivate trial. You know, this is using anibrutinib for 12 further cycles. So really 15 months of therapy. This was kind of everyone was done at 15 months, but there wasn't a MRD trial. And so it really was an assessment not only of how impactful this therapy can be as a time-limited therapy, but also what you were seeing with regards to undetectable MRD and the ability to take those patients who have detectable MRD after 3 months and potentially making them undetectable MRD. And really, I think what we're going to need to do here is really look for long-term follow-up of the Captivate trial. It really looks like to me that it's elevated up the 17p deleted or the 2p3 mutated CLL population, a cohort that we're really, needing, I think, therapies, novel therapies for really to prolong the durability of survival in this high-risk population. Secondly, I jumped to what I thought was the most surprising abstract from ASCO 2022, and at least in my non-Hodgkin's lymphoma, which was the rosewood trial, which was zandalis plus obinutuzumab versus obinutuzumab monotherapy. What surprised me about this trial is, historically I haven't really thought about BTK inhibitors as a therapy in relapsed refractory follicular lymphoma. I know that it had been tried in other trials, but here, really not only did it meet its primary endpoint, looking at overall response rate, but when you looked at it at the end, in this 2 prior line patient trial in follicular lymphoma, there was actually an overall survival advantage for the patients that got zandalis obinutuzumab versus those who received obinutuzumab monotherapy. And so that was surprising to me, but what was also interesting was the fact that looking at the zandalis arm, there really wasn't a significant amount of additive toxicity when you added it to obinutuzumab. The next the next trial that I talked about was the tidal trial. So this is a PI3 kinase inhibitor in relapsed refractory follicular lymphoma. And this was looking at a PI3 kinase with a different dosing strategy where patients were given kind of daily therapy at 60 milligrams for the first 2 cycles or 2 months. And then we're given kind of an interrupted therapy where they received it between days 1 to 7 on a 28-day cycle and continued until progression, toxicity, or the subject didn't want to take it any further. What I liked about this trial was the intermittent dosing strategy to try and reduce the risk of adverse events of interest, namely your itises that have been seen in other PI3 kinase classes, and has led, I think, within some of the CLL PI3 kinase studies, some adverse outcomes were seen in PI3 kinase inhibition. There was a 70% overall response rate with what I thought was a CR rate that was quite respectable across kind of different disease states, meaning POD24, depending upon the line of therapy. So I really think we need to see where this, where zandalis goes, what the long-term durability is, what the long-term toxicity profile is, and where it's going to fit in the relapsed refractory follicular lymphoma space, because there's a lot of activity there. Then I moved on to zilovertamab. Zilovertamab is a monoclonal antibody against ROR1. This was tested in mantle cell and CLL, and then we saw a little tickle of data on it paired with a BTK inhibitor, ibrutinib. There we saw respectable waterfall plots. We saw doubling of complete response rates compared to historical data between ibrutinib monotherapy and the combination with a CR rate of 40% in this trial. Again, I think we're going to need to see long-term data, both as a monotherapy and as a combination therapy, and how will this partner with other therapies, potentially like bispecific therapies, other BTKs, and potentially with chemoimmunotherapy. Then I moved on to the SHINE trial, which was a randomized double-blind trial of BR followed by maintenance rituximab plus ibrutinib or a BR plus maintenance rituximab without ibrutinib. And again, this is a placebo-controlled trial. This did meet its primary endpoint of prolonging PFS by 2.3 years. There was no overall survival advantage. I thought it was interesting to look at the toxicity profile of both the placebo arm and the ibrutinib arm, both in regards to incidence of high-grade hypertension as well as arthralgias in that placebo setting. And I think this is really where you get the opportunity in a large population to tease out really what are the toxicities to ibrutinib. In regards to its utilization, I think that it did meet its primary endpoint, but that primary endpoint, how meaningful it is and impactful to clinical practice, it's unlikely to change my practice. I will likely still give chemotherapy in mantle cell lymphoma, followed by a BTK as second line, and I would expect similar PFS. But overall, a very large trial in mantle cell lymphoma, and congratulate those investigators on that trial for really putting patients on in a very short period of time and presenting this data. The next that I moved on to is the Echelon 1 trial, where I was really speaking about the overall survival advantage that I didn't expect to occur in the brentuximab vedotin AVD arm when compared to the ABVD arm in advanced stage Hodgkin's lymphoma. I do think that it was very interesting to look in the ABVD arm that there was a significant amount of secondary malignancies in that arm, and they were hematologic malignancies. So I think that were related to death events on that trial in the ABVD arm. So I think there's a lot of interesting data. It is a survival advantage for the BV-ABD arm in advanced stage Hodgkin's lymphoma. I do think that this will and is practice changing. I think the subsets that were there when we saw the modified PFS events of male high IPS score, residing in North America were interesting tidbits in the forest plots. But I think now this may be more universally used, with the caveats that growth factor use is likely necessary, and it may be a little bit more. The patients may feel it a little bit more than ABVD. So I think we just have to continue to grow our experience with this regimen. And then the last in the kind of non-CAR T cell area I talked about was in relation to the Polarics trial, and really looking at pathologic immunohistochemistry markers of what was a double expressing lymphoma, followed by BCL2 expression, followed by MYC expression. And kind of in that class, I think that when you look at more specifically the double expressing lymphoma cohorts, that really in the Pola-R-CHP arm, it really did raise up that curve in the double expressing lymphoma. So I think for a subset that you could probably get in the 99% of areas where you are getting a diagnosis of diffuse large B-cell lymphoma, that those immunohistochemical stains should be available to the masses. And so I think that this just encourages or strengthens the Polarics data in that based upon pathologic features. I then transitioned over to CAR T-cell therapy, where I spoke a little bit on kind of the ongoing controversy that is ZUMA-3. I don't think it's a controversy that in relapsed refractory adult ALL that this therapy can work, but really what do you do in those patients who get a CR? When do you let them ride without a consolidative allo transplant? Or when do you go on to an allo transplant? And I think that the data kind of supports that that age certainly isn't a barrier to potential efficacy, but also the blast count at the time of cellular therapy may matter with those in regards to outcomes. I then transitioned to the pilot trial. I think the pilot trial is with lisocabtagene maraleucel or liso-cel, and this was done in individuals who had relapsed large B-cell lymphoma who weren't intended to undergo a transplant. They had very high risk disease, kind of comorbid conditions, if you will, which could include decreased DLCO, decreased creatinine clearance, decreased left ventricular ejection fraction. Also on top of these individuals were all or could have been age greater than 70. you had to meet at least one of these criteria. So you didn't have to be 70 or older, but you had to have one or more of these comorbid events beyond just age, and you were felt to be not transplant eligible. Here, really, I think in this higher risk population, in the second line setting, you really saw good overall response rates with CR rates, I believe, is at 54%, without any significant toxicities that I wouldn't have expected when you look at liso-cel in Transcend and also in Transform. Transcend being the third line beyond, and Transform being kind of in that transplant eligible randomized trial population. So I really think that the pilot data supports that age isn't a barrier to CAR T cells. Some comorbidities may not be a barrier to CAR T cell in that regard. I also spoke about the ZUMA long-term follow-up of the ZUMA-2 trial, which was in relapsed refractory mantle cell lymphoma. Again, those patients had to be exposed and relapsed or refractory to a BTK inhibitor in mantle cell lymphoma, and we really spent some time, reflecting on what are the therapies in relapsed refractory mantle cell lymphoma after BTK failure, and just how those outcomes do appear to be quite poor. When you look at the ZUMA-2 data, there was impressive overall response rates of 91%, with, I believe, the CR rate rolled around in the 60% range. I really want to continue to follow the long-term outcomes of these patients to see if there is a tail on that curve. I'm kind of concerned with some of the relapsing events that appear to be happening in these patients who achieve a CR. But again, CR in cellular therapy does matter. And lastly, I looked at the real-world outcomes of axi-cel in the CIBMTR database in those patients with relapsed refractory diffuse large B-cell lymphoma, the majority of them, if not all of them, being in the third line and beyond, and looking at it not only by kind of where they were, where the commercial CAR T cells were done across the United States, but also breaking it down by race and ethnicity. From a race standpoint, they looked at white, Black, or African American, as well as Asian. And there you can see very, I think, across the board, similar overall response rates and CR rates. There was some differences numerically in regards to the area of the vein-to-vein time, which is from apheresis to infusion. And this is after, I made the point about this is after insurance approval. So really these delays are likely, less likely with axi-cel to be due to manufacturing issues, more likely due to patient issues, whether or not it's infection or trying to get the disease under control to make them so that they're in a condition that they can go on and get CAR T-cell therapy. So you saw that potentially a little bit higher in the African American or Black population. The median PFS in that population was shorter than the white or the Asian populations. However, in those who did not progress, the Black or African American population did appear to do equally as well with regards to PFS and overall survival. I do think that there are classes that I didn't speak about in my talk during the time that I was given, namely those about the impact of bispecific antibodies that we did see at ASCO with regards to glofitamab in large cell lymphoma, and also the other bispecifics that are CD3, CD20 engaging therapies in the relapse refractory NHL space. With that, I thank you for listening to my summary from ASCO Direct in Denver, Colorado. Y'all have a great day.